Foundation in association with the Project iEcho from the University of New Mexico. These sessions are held weekly on a Wednesday. Please remember that the chat is open for any questions that you may have. We've got our gastropathology session today, and I will be presenting a case, an interesting case, a patient that was transplanted for Wilson's disease back in 2015 that I noted a mildly abnormal LFT brewing. And then Dr. Johan Buerter, a gastroenterologist from Santon Mediclinic here in Johannesburg, will be sharing a further autoimmune case with us straight after. So for me to dive into my young lady, she was transplanted at the age of 16, where the diagnosis of Wilson's disease was made based on her presentation of neuropsychiatric symptoms, as well as her biochemistry, including an elevated urinary copper and low ceruloplasmin. We did not have genetic testing to 100% confirm that, but the explant histology was further suggestive of this process. She did very well post-transplant, and is currently a graphic designer holding down a full-time job, and is 22 years old at the moment. She had, for the past probably about a year or so, she'd had mildly abnormal LFT, ALT, ASTs of approximately 40 to 50, certainly not all too dramatic, but enough for us to be looking at it with some concern. We also noted that her globulins were slightly elevated. About 6 to 8 months ago, a liver biopsy was discussed, and she was not all too keen. And considering the low degree of inflammation, we also felt somewhat hard-pressed and let it go. But when we saw that these changes were persisting, we went ahead with a full autoimmune workup, including a liver biopsy. Her autoimmune marker was sitting at ANA was sitting at 1 in 320, and her globulins elevated at 32. That's IgG, elevated at 32 when we did the biopsy. And Prof, I'll hand over to you with that for the presentation.
Right, thanks, Bilal. So we've chosen these two cases. And the reason why we've chosen these two cases is because we have noticed that autoimmune hepatitis in our population can progress at a fairly alarming rate. And if we think patients have autoimmune hepatitis, I think the message that hopefully we will convey to you this afternoon is one that should be investigated sooner rather than later, and particularly using biopsy to see how the disease is either being kept at bay or is progressing. So the first patient then, as Bilal said, is this young woman, as you have heard, previous history of Wilson's disease. And in this particular instance, we've got a very good biopsy. We've got a good representation of tissue. I can't go any lower than that, unfortunately. See if I can. Yeah, there we are. So there you can see the architecture, and those of you who have some experience in histopathology will certainly see that the architecture is abnormal. You seem to have nodules of hepatic parenchyma, which are separated by these broad bands of fibrous connective tissue. And if you look in the fibrous connective tissue, you can see that there are blue areas. And you will have heard me talk previously about the so-called blue biopsy. When we see blue cells like this, one becomes very concerned. Are you dealing with an autoimmune process? So that's what the biopsy looks like at low power. And then if we put the reticulin on, you can see that the nodularity is more pronounced. You can see the broad bands of fibrous connective tissue. And when we go down and have a look at some of these nodules, the section is a little bit overstained, but certainly there seems to be twinning of hepatocyte plates. Turning now to the collagen stain, this is the Sirius red. Once again, this low power examination, and you can see quite clearly this nodularity. So this patient has unfortunately progressed to cirrhosis. Right, so then the next step is to determine the cause of that cirrhosis. And as I've mentioned to you already, when you see a sort of what I call the blue biopsy, then you need to think very seriously, could this be two things that would come to mind? The first would be autoimmune hepatitis. And the second, for example, where you get quite an intense lymphocytic inflammatory infiltrate, like this would be chronic hepatitis C infection. So when we have a look at this biopsy, we see that we've got this aggregation of these lymphocytes, and interspersed amongst these lymphocytes, there are large numbers of plasma cells. We concentrate on this area here, you can see the aggregation, and in this particular instance, there's no definitive evidence of germinal center formation, but there are a few larger lymphoid cells, such as this one here. And these would be centroblasts, and that would suggest that there possibly is an evolving germinal center, which is going to happen into the future, but certainly no definitive germinal center. Then as far as the other cells are concerned, interspersed amongst these, you can see that there are numerous plasma cells. Now, these are plasma cells here, there, yeah, these are all plasma cells. And when you see plasma cell clustering, that becomes almost definitive from the point of view of diagnosing autoimmune hepatitis. And if we look there, for example, you can see that there is a whole row of plasma cells. These are all plasma cells here, quite characteristic of autoimmune hepatitis. And the other thing that's also happening is that there is evidence of interface inflammatory activity. And here you can see the lymphocytes that are infiltrating into the interface, as the name implies, between the hepatic parenchyma and the fibrous connective tissue bands. And if we look down here, oops, possibly not such a good area. I'll find another one, but I think these are plasma cells. Go and search for plasma cells elsewhere. Right, so here we've got a portal tract. You can see the bile duct, hepatic arteriole, and then you've got this interface inflammatory activity. You can see that we've got sinusoidal leukocytosis. Many of those are lymphocytes. And then this is a focus of interface inflammatory activity with lobular activity as well. And here you can see we have participating plasma cells in this. So here we've got a group of plasma cells participating in this interface inflammatory activity and lobular activity as well. And again there, more interface inflammatory activity. So this is extremely active. If you look along this interface region here, you can see that there's extensive interface inflammatory activity there. Right, then the last thing I want to show you is what we call emperipolesis. And emperipolesis is the phagocytosis of lymphocytes by hepatocytes. And it's quite tricky to pick up lymphocytes and make sure that they're actually sitting in a hepatocyte as opposed to in a sinusoid. So here, for example, just find it. I found it and then I've lost it again. I'll pick it up on the screen. Right, here we are. So that's a lymphocyte, which is being phagocytosed by the hepatocyte. That's the hepatocyte nucleus. And I think that could also be that little focus. I think that is also, I think those are probably two lymphocytes also that are also being phagocytosed. But I'll show you what I mean by it being difficult. So for example, if we take this cell here, so that's a lymphocyte as well, but that's actually sitting in a sinusoid. So it'd be quite tricky to see that. But having said that, emperipolesis of lymphocytes by hepatocytes is said to be pathognomonic of autoimmune hepatitis. And in fact, if you then do the CD lymphocyte subsets, typically the lymphocytes are CD8 positive that are being phagocytosed. And that's another feature of it. There's another lymphocyte, for example, which I think is probably being phagocytosed. I think that might be a lymphocyte there sitting in a vacuole. But it is, as I say, quite tricky. Right, the next thing I want to turn to are the bile ducts. And very important when you look at patients with autoimmune hepatitis to make sure that they haven't got an overlap syndrome. And if we look at the native ducts, for example, this one here, you can see that that duct is looking perfectly fine. There's no evidence of any periductal inflammation. The duct is fairly uniform in shape The nuclei are uniform in size and color. Those are all changes that happen in cases where there is inflammatory mediated bile duct injury. You look there, the same sort of thing, where the bile duct is all right. There's no evidence there of any lymphocytic cholangitis, because you also get what's called lymphocytic cholangitis as well in patients with autoimmune hepatitis. Another bile duct that is also morphologically normal. So it doesn't appear as though there is what we call an overlap syndrome. And then the last thing that I want to turn to is are the venous structures. And here we've got a portal tract there. And this, I think, is a central vein there. And what we've got here is we've got a central vein. We can see that there is disruption of the endothelium of that central vein, or the hepatic vein. And that's resulting in a quite extensive red cell extravasation. You can see the lifting of the endothelial cells, and you can also see the perivenular inflammatory infiltrate, which you've got at the periphery, and the numerous plasma cells that are present in this inflammatory infiltrate. These are all plasma cells. See all these plasma cells, large numbers of them, and they're clustering. And then on top of that, you've also got what we call perivenular extinction. And that's really just a bit of a fancy word to describe the hepatocyte dropout that's also occurring in zone 3 around the central vein. So this is endothelialitis that also occurs in patients with autoimmune hepatitis. So this is a case then of classic autoimmune hepatitis, which is occurring in a patient who has had a liver transplant for Wilson's disease. And because the pre-existing disease was not autoimmune hepatitis, we call this de novo autoimmune hepatitis. The patients below can go more into the treatment of these patients, but they are treated as a rejection. The therapy is modified to counteract the effects of the plasma cell infiltrate and specifically the autoimmune drive that's happening. But this is a classic autoimmune hepatitis, and as I said, we would call this a de novo autoimmune hepatitis because it is occurring in a patient whose pre-existing liver disease was not autoimmune hepatitis. If this patient had, for example, a liver transplant for end-stage disease secondary to autoimmune hepatitis back in 2017 or 2018, then we would call this recurrent autoimmune hepatitis as opposed to rejection. Bilal, I think I've covered that. Over to you.
Yeah, absolutely. So,
I think this case was kind of we chose to highlight this case just in terms of
how disease can occur with
relatively normal enzymes. You don't need rip-roaring enzymes to have a significant amount of inflammation and fibrosis form.
And it is important to look at your other markers, look at monitor your platelet count, have a high index of
suspicion for inflammatory activity. I think number one, looking at autoimmune
hepatitis, your targets to your treatment
should be true normalization of your liver enzymes. So, in a 20-year-old young female,
where we were sitting with enzymes of 40 and up to 50, these were actually 2 times up limit
of normal that we should have accepted.
Where we have an elevated globulin,
this was the other clue for us to start paying more attention. Luckily, her platelets are still preserved and there's no other features of decompensation. So I have adjusted her therapy. In terms of de novo autoimmune hepatitis, these patients are often if they're on CellCept, switch to azathioprine, or vice versa, remembering that both are active against autoimmune hepatitis, with azathioprine being your first-line therapy. And then I have increased her steroid, or I've given her a steroid course for the next few weeks with a taper. And I'm going to assess and see what that does to the globulins. There are other treatments available because these autoimmune de novo autoimmune hepatitis in transplantation can sometimes prove to be difficult to control. This particular young lady was on extended release tacrolimus, running levels of approximately 4 to 6, being 6 years out from transplant, as well as mycophenolate mofetil at 500 milligrams BD. So, yeah, beware. Let's try and get to your targets. Normalization of IgG and normal ALT/AST.
Bilal, just give us the time sequence again from the diagnosis of Wilson's, the transplant, and then when this autoimmune hepatitis.
2016 transplanted. Had a bit of a
so diagnosis of Wilson's was when?
Was 2016.
Okay, at the time of transplant.
At the time, 2015, call it.
Yeah, 2015, 2016. It was, she was one of these decompensated patients that came in and was worked up towards transplantation. She was not my patient at that time. She was my colleague, Professor Annie Song, managed her through that period. And when I took her over on Prof. Song's retirement, she was doing very well. Pretty much normal LFTs, and that seemed to have persisted all the way up until I'd probably say end 2021, when we had our first little blip. We adjusted our immune suppression, and on into 2022, when it seemed to dip downwards slightly before cracking upwards once more, and then we never got it quite normal. We had, I think, at its peak an ALT of 90, but that was only a once off. And with these transplant patients, if they pick up a virus or something like that, you can expect some degree of fluctuation.
So this is progressed
where it went up to 90.
So this is progressed.
I would say about 18 months. No, months, right? I mean, looking back to when, we first documented that globulin rise was probably in 2021, and this now up until I think we biopsied her in July or August of this year. Where we've been talking about, should we biopsy? Should we, see what's going on? That sort of scenario. We still had normal platelets. We've got normal full full blood count. It was just really a mildly elevated ALT/AST, as well as globulin, normal bilirubin, and normal albumin.
So clearly, the post-transplant setting must play a role in affecting the rapidity.
So this is a case that we're
actually trying to, just review from the initial diagnosis. It's a pity that in terms of the timing, because the NHLS DISA laboratory service has switched. So we wanted to review the explant, and Prof, I still owe you that those details. We're going to go through and just review her case from that point of transplant to now. I am questioning this diagnosis of Wilson's now, in retrospect. Wilson's can be such a great masquerader, and can be difficult to diagnose, especially where there is some degree of cholestatic liver disease. I do recall her from the ward at the time and remember her being quite a significantly decompensated young lady who Prof had kept admitted from the point of listing until she got transplanted, because she was just too ill to go home. So yeah, she's an interesting one, and I think our, where we've called her a de novo autoimmune hepatitis, I think, I put a little asterisk on it because it's potentially subject to change once we go through the full review of her explant histology.
Yeah, thanks, Bilal. I mean, certainly I agree with that. We would have to we'd have to confirm the explant histology and see what that shows. But I think as has been discussed, we've picked this up now, where these patients, both in the transplant setting and also without any transplantation, it seems that there's a cohort of patients that can progress from non-cirrhotic liver to cirrhosis in under 2 years. And we've seen that now in a couple of patients. And Chris, you've had a couple of those patients as well.
I mean, as we keep making the point of, it's the one disease that frightens us enormously. And I think it is unique in all forms of chronic liver disease. I don't believe viral hepatitis, either B or C, have been described to develop cirrhosis in such a short time. I think C initially was described in about 5 years, if I remember, but in under 2 years, it would be a bit unusual. So this is a unique disease.
Yeah.
And that's why it's imperative to make sure those enzymes in the treatment are absolutely normal and very well normal, not just petering upper limits of normal.
Yeah.
Shall we go on
To Johan's case, it's 5 o'clock, so halfway through the session.
Right. Good afternoon, everybody. Can you hear me?
Yeah, we can hear you loud and clear.
There you go.
Sure.
Go ahead. Thank you.
Okay. The next patient is a 55-year-old woman who really, to all intents and purposes, was asymptomatic when she first saw me. The reason for the referral was that she'd had abnormal liver function tests over several months, which her general practitioner had basically just been watching. And when I say the abnormal liver function tests, the alkaline phosphatase and GABA-GT had been consistently normal, but the ALT had varied between about 150 and 210, and the AST from about 115 to 124. So when I saw her, one of the striking features was that she had a raised globulin on the standard liver function test of about 37. And subsequent investigation then revealed that her IgG was in fact raised at a value of about 23, with a normal range of 6.5 to 16. And her anti-nuclear factor was positive. Initially, it was at a level of 1 in 80 and subsequently 1 in 160. And a subsequent autoimmune liver screen then revealed that the patient's the anti-soluble liver antigen antibodies and the anti-liver pancreas antibodies were both strongly positive, as well. They were positive, as well as the RO52 was strongly positive. So at that point, a presumptive diagnosis of autoimmune hepatitis was made. In fact, before we got to that, this patient had not really been exposed to any drugs that one could implicate in terms of autoimmune hepatitis. However, she was taking a number of over-the-counter preparations, and this was stopped for a period of time before the decision to do the biopsy was made. And, well, then we'll see what that shows.
Prof?
Okay, thanks, Johan. I don't know if there are any further questions on that history. Okay, so let's go through this biopsy, and you can see, having looked at the first biopsy, the degree of similarity between the two. Once again, you can see there's a bit of a nodular architecture to this. And the other thing that is also apparent are these blue foci, as I showed you in the first one, such as there and there. And if we look at this particular area here, we can see that the nodularity is more intense. We've got clear separation of some of these nodules. But once again, this propensity for the so-called blue biopsy. So bearing in mind that we've got this nodularity there in this region here, when we look at the rest of the biopsy, we can see that that's relatively bland. I mean, there is nodularity, I think, which one can see, but it's not quite as well demarcated as in that first focus. So let's go down and have a look. So first, before we do that, we'll just have a quick look at the reticulin stain. And if we look at the reticulin stain, same magnification, you can see that at this end of this biopsy, that nodularity is not really coming through on the retic until you get to this area down here. A little bit of expansion of the portal tracts. There's some fibrous septum formation. And this is that area here where I showed you was that increased nodularity. You can see the septum, two septa here, there, and there that are starting to approximate one another. And I think you will agree that they're starting to see circumscription of hepatic parenchyma by collapsed reticulum. We go to the Sirius red. Once again, starting at the end of the biopsy, going in the same direction, you can see the expanded portal tracts. You can see the septa that are being formed, such as you see there. And then we get to that area here, which I've shown you on the retic and the H&E, and you can see that this nodularity then becomes more accentuated, and we're starting to get complete circumscription. Now, the fact that we haven't got this change present throughout the biopsy suggests that this is not cirrhotic, but certainly we've got evidence of architectural distortion here. So let's go back now to the H&E. And you can see here that we've got this quite intense aggregate of lymphocytes. There's no germinal center formation, but at the periphery, we can see that there are a significant number, or there is a significant number of plasma cells, such as you see here. And then as we move along, we see that there are foci of interface inflammatory activity. So you can see the interface activity here. And once again, there are participating plasma cells, such as you see here. So it's almost identical to the previous case. And then that picture repeats itself through all the portal tracts. And then I want to show you this area here. And I think in this area here, you've got the beginnings of a germinal center. So this sort of picture here, I think that's the beginnings of a germinal center. So we've got a follicle, a lymphoid follicle, which is being formed. Right, so let's now look at the bile ducts. So for the most part, the bile ducts in this particular case look all right. So for example, if you look at these bile ducts here, you can see that that duct on the edge there is fine. There is no evidence of any periductal inflammation, a little bit of variation in nuclear size, and I think that's within the grounds of normality. Bile duct there, I think you can see it's completely separate from the rest of the inflammatory infiltrate, and that is fine. And the bile ducts throughout all those portal tracts show the same histopathological features. But when we get to this other end, up here, the picture changes. And there we've got a bile duct, which is showing lymphocytic inflammatory infiltration. You can see the cellular injury that is taking place in the biliary epithelium. You can see that the bile duct epithelium is starting to become fragmented. You start to see vacuolation, and we have physical infiltration of this biliary epithelium by lymphocytes. So we're starting to get fragmentation of that duct. And then if we look at the periphery here, I think one could see that there is, whoops, just kind of look, so if you look here, you can see that there are epithelioid histiocytes. So some of these cells here are epithelioid histiocytes. In fact, I think a number of them. And it would appear that these epithelioid histiocytes are in fact encompassing or encircling this bile duct. So when you see epithelioid histiocytes and evidence of bile duct destruction, one has to think of PBC, or primary biliary cholangitis. The next step then is to say, well, are those changes occurring anywhere else? And the answer to that is no, not obviously, not that we can see. So the next trick is to have a look at the Aursine stain. And the Aursine stain in this particular instance is negative. And to show you what copper-associated protein looks like, so this is the control, slide. And a good Orsine, which shows copper-associated protein, is the best one to use. A lot of people use the elastic tissue to decide whether the Orsine stain has worked or not. And in fact, that's not really a good indicator. What you need to do is actually choose an Orsine stain that's got copper. And here you've got this abundant intracytoplasmic copper-associated protein in the hepatocytes adjacent to the fibrous connective tissue. This is a patient who's got cirrhosis, and the only place to find the copper, in fact, is adjacent to the fibrous connective tissue septi. If it's really advanced, it may extend into the rest of the nodule, but often it doesn't. And in fact, the best place and only place is adjacent to the either the portal tract, in case if the patient hasn't got cirrhosis, or in the paraseptal hepatocytes in those patients that do have cirrhosis. So there's lots of copper there. And to show you what that looks like, and then if we move to the patient, and have a look at that, you can see, I won't go through the whole thing, but you can see, in fact, that the zone 1 hepatocytes show no evidence of any copper. Now, it's important, in fact, to actually go through all the portal tracts that are present in the biopsy, because sometimes it's just one or two that show the copper-associated protein, and that gives you the answer that you're looking for. In other words, that the patient has chronic cholestatic liver disease, because that's when you get the accumulation of copper. And the other trick is also to look, for example, in this particular instance, at that portal tract that shows evidence of bile duct injury, because often you get copper associated with those particular portal tracts and not with the others. But that's the injured bile duct, and here there is no evidence of any copper. So the question then is, what's the diagnosis? So the diagnosis here, I think, is cirrhosis, at least not cirrhosis, is autoimmune hepatitis. I think from a metaverse score point of view, I think she's probably an A2 because there is evidence of interface inflammatory activity. There is also evidence of lobular activity as well. And then from a score point of view, I think predominantly an A2, but there are foci of F3 type of fibrosis. I think that there is evidence of potential bile duct injury, as we saw in this particular area here. I'll just go back to this. So this is the patient that needs to be watched for possible evolution of an overlap syndrome. So this sort of thing here, you need to think very carefully and watch carefully for a possible evolving overlap syndrome into the future. And that, as we know, can certainly happen. There's evidence of lobular activity as well, this sort of thing here, spotty lobular inflammation. And then the one thing that I didn't mention that I showed you in the previous one was endothelialitis. And there's also a little bit of endothelialitis here in this particular patient. There's a portal vein, and I think there's a bit of subendothelial aggregation of lymphocytes there. Some of this may be artifactual disruption. And possibly here a little bit of subendothelial aggregation of lymphocytes beneath that portal vein. You don't always get the endothelialitis. Here, I think in that portal vein, there's an attempted endothelialitis here. So that's that particular patient. So two patients also who's, as you've heard Dr. Porter say, asymptomatic, abnormal liver function, and yet has quite significant liver disease. Over to you, Johan and Bilal.
Thanks, Prof.
Johan, so how, I'm not sure when this biopsy was done. Just wondering on how you managed the patient and response to therapy so far.
Well, the biopsy was done very recently. So at the time, I didn't have, I would always do the thiopurine methyltransferase before, or the genetics for that before starting azathioprine. So she has been started on prednisone. She's a relatively small woman, not a relatively, she is a small woman. And so I started on 30 milligrams of prednisone with the intention of possibly introducing azathioprine at a later stage. And this was only very recent, and so I haven't really got any feedback on the response to treatment.
Okay. Yeah. So, I mean,
You know, that's just for the fellows, remembering that azathioprine, it can be associated with drug-induced liver injury. So, you know, by you sequentially introducing prednisone and then the azathioprine at a later stage is the proper way to manage these patients, and you'll be able to pick up any funny business with your azathioprine at that later stage.
yeah. So
let's hope she has a good response to that, and that she doesn't evolve like Prof was suggesting. I'm not sure if I can open up to any other comments or here we go. Wisdom. Would it be appropriate to perform a gastroscopy exam now? Have you? What's your thought on that?
Well, presumably that would be if we're looking for evidence of portal hypertension. There's no, well, I suppose portal hypertension and any other foregut pathology. She's certainly asymptomatic from that point of view. And from a portal hypertension point of view, clinically, there was nothing to find, and her platelet count is well preserved at about 200,000.
Right.
So Bilal,
anyone else with?
Bilal, the other thing I should probably just mention as well, with that bile duct injury that's occurring in Dr. Porter's case, the fact that the serology is negative and that she's asymptomatic at this stage suggests that we should probably also think of this entity of what the literature refers to as autoimmune cholangitis. But I'm not sure how many of those cases of autoimmune cholangitis then become PBC. But I don't know if you guys, from a medical point of view and a physician point of view, what you think of that as an entity, autoimmune cholangitis.
So autoimmune cholangitis, when you've got the cholangiopathic features, make sure that the IgG4 has been looked at. But the good thing about it is that it kind of responds to the steroid and azathioprine as well. So you can expect a resolution of both with that. You can get the large duct biliary changes with autoimmune cholangitis as well. If you're referring specifically towards the IgG4 type cholangiopathy. And is that what you're referring to, Prof?
No, so we regard IgG4 sclerosing disease as a different entity. There you will get a styrofoam type of picture with which is rich in IgG4 positive plasma cells. So autoimmune cholangitis we see as a separate condition. It's really sort of mentioned McSween's book, and it's there as a sort of as an entity to think about. It doesn't really go. They don't go into much more detail about that. I think this whole question of autoimmune disease in the liver can be quite complex, or it is complex.
So, Martin, how does it
A
differ?
question on gastroscope links.
Sorry,
Martin,
Chris,
how does it differ from primary biliary cholangitis?
Yeah, Chris, I think that I think is the issue. I think if it's seronegative, I think McSween says if it is seronegative,
Okay.
then you call it autoimmune cholangitis. If it is seropositive, then you would call it PBC.
But it's kind of more on the spectrum of autoimmune hepatitis rather than primary biliary cholangitis.
Yeah, correct. Yeah, more on the spectrum of autoimmune hepatitis.
And that's why it probably responds to steroids and azathioprine.
Yeah. Yeah, and you see, I think that the question then arises, I mean, from a histopath point of view, and also, working with you chaps, is, would this patient go on to URSO at all? With a view to stopping any potential bile duct pathology.
As a preventative thing. I mean, there's evidence for that as a post-transplant.
Your post-transplant patients for PBC, you look at putting them on URSO to prevent recurrence, but I don't think we can. I don't think we can necessarily do that here. I think what we should do is try and get the autoimmune aspect under control. Potentially look at a repeat biopsy in the next year. Allow things to truly settle and then reassess those ducts. My concern for an autoimmune cholangiopathy, PBC, vanishing bile duct type syndrome is that we've got a fairly asymptomatic patient. She's not presenting with any typical cholestasis features of pruritus or significant fatigue, and we don't really have serology to back it either. Antimitochondrial, ANA, GP210, SP100, all negative. The only thing that is concerning is the row 52 that's positive, and that would then be associated more with the Sjogren type vanishing bile duct. And again, you've got someone that's relatively asymptomatic. I think we clear the field of any confounders and then reassess.
Yeah, right.
Okay.
The
Wisdom's got a further comment here. A question on gastroscope links the comment from Prof. Hale on overlap syndrome and the fact that portal hypertension develops earlier in PBC overlap syndrome patients. And will you then consider statins as part of the treatment armamentarium? Anyone want to take that? So my personal comment is that I'm using statins more and more frequently for any form of cirrhosis. Right now, Prof, just remind me, the extent of the fibrosis was F2 to.
Yeah, she's predominantly F2 with a little bit of F3.
Yeah. So
Wisdom, we don't necessarily have established cirrhosis here. We've got more at a push clinically advanced fibrosis. If we consider that our platelet count is still in normal range, it would make the concerns around portal hypertension less. I think certainly if she had portal hypertension and established cirrhosis, a statin would certainly come into play. More so, don't forget your fibrates for your patients with PBC. The BES-ESO trial showed that you can push patients who don't have a complete response on ESO to normalization with the addition of a fibrate. Otherwise statins are certainly something that you'd consider if there was cirrhosis.
Agree.
And then remember, early beta blocker. Carvedilol, I think, is now being shown more and more to prevent decompensation. The early work done by the Predesi trial confirmed that carvedilol is your choice of beta blocker, and once that's on board, you have a delay to first onset of especially ascites, and I think that was specifically in the Predesi trial, but there have been subsequent studies validating that finding. So beta blocker at an earlier stage, and I think from me personally, if she was more of an F3, if Prof was leaning more to F3 fibrosis than F4, I would be considering, I'd be toying with the idea of statins as well as beta blockade at that sort of point.
Anybody else have anything? You have 1 minute. 1 minute to win it.
So 5:29. But if not, I will start wrapping up. And I'd like to thank Prof. Hale, as always. He is significantly jet lagged, having just gotten off the plane from Toronto. So hats off to the good professor for making the effort and being here for our education. These sessions are always fantastic. To Johan, thank you as well for your fascinating case and presentation. It's much appreciated. It really does. It's really fantastic when people like Wisdom come online and are able to comment, and all of us get to learn with these cases. So much appreciated. And then finally, to our good chairman of the Gastro Foundation, Professor Cassinides, the rest of the Gastro Foundation Project ECHO team, the ECHO team sitting in India. Aditi, thank you so much for being online. That's the ECHO University of New Mexico team and ECHO India team. Thank you for your support and getting this going. Cheryl, thank you for corralling us and getting us going. Recordings, remember, are available on the Gastro Foundation website. Thank you to our sponsors. Next week is upper endoscopy session. Who is doing that?
Chinnery.
Okay, with
the fantastic Galia. If you've been at one of our fellow weekends, you'll know that she has a wealth of knowledge to share, and I hope a few pictures and videos on that. Thank you, everybody. Enjoy your evening.
Thanks, Bilal.
Thank you.
Thank you very much.
Cheers. Thanks, Johan. Thanks.
Cheers,
Bilal.
Bye-bye.
Bye.